Okay, welcome to the deep dive.
Hello.
Today we're diving deep into something that sounds pretty intimidating but is absolutely crucial to understand, especially if you're prepping for medical exams or just want to get your head around complex conditions.
Yeah, we're talking about Guillain-Barré Syndrome, or GBS.
Exactly. And our source material for this deep dive, it's a really solid stack of comprehensive MSRA revision notes.
Right, they're packed with detail. But our job today is to, cut through that, pull out the absolute must-know facts, the high-yield stuff.
Basically giving you that essential shortcut to really grasping GBS, whether it's for revision or just general knowledge.
We're going to unpack these notes, highlight the core facts, maybe some surprising bits too, and really focus on what you need to recall.
Okay, let's jump right in then. What is GBS at its absolute core? The definition from the notes.
Okay, so definition-wise, GBS is an acute inflammatory polyneuropathy.
Right, let's break that term down a bit. Acute.
Yeah.
That means it comes on fast, right? Suddenly.
Yeah, exactly. Rapid onset, we're talking days, maybe a couple of weeks usually.
And inflammatory. That points to the immune system getting involved somehow.
Precisely, the immune system attacking. And then polyneuropathy just means, multiple nerves.
Multiple peripheral nerves all over the body.
Yeah, affected throughout the body.
So suddenly, lots of nerves are inflamed, under attack, and the notes highlight that it's often triggered by infections. That's a key thing.
Oh, absolutely. That's a defining feature. The notes specifically mention Campylobacter jejuni. That's a really common one, often after, a diarrheal illness.
Okay, Campylobacter, what else characterizes it? The notes mention weakness.
Yes, progressive muscle weakness. And it typically starts in the legs and sort of climbs upwards, that classic ascending pattern. That plus loss of reflexes, which is called aphlexia.
Ascending weakness and arflexia. Got it. And this attack, it's autoimmune, right? Your body attacking itself.
That's the main theory, yeah. The notes talk about molecular mimicry.
Molecular mimicry, what's that exactly?
So basically, your immune system creates antibodies to fight off an infection, say Campylobacter. But sometimes these antibodies mistakenly recognize parts of your own peripheral nerves because they look structurally similar to the bug.
Ah, so the antibody thinks the nerve is the invader because it looks alike.
Exactly. It's like a case of mistaken identity on a molecular level, leading the immune system to attack the nerve tissue.
Wow, that's... Oh. Yeah, it really shows how a common infection could potentially trick your immune system.
It's that complex interaction. The notes also mention different types, different variants of GBS.
Right, I saw ADP, that's the most common, but also things like AMSM.
Yep, ADP. Acute inflammatory demyelinating polyradicular neuropathy. That's the classic, most frequent form, where the myelin sheath, the nerve insulation, is the main target.
Okay, demyelinating.
But then you have AMAN and AMSAN, acute motor axonal neuropathy, and acute motor sensory axonal neuropathy. Those involve more direct damage to the nerve axon itself, the core wire.
So axon damage versus myelin damage.
Kind of, yeah, though there can be overlap. The notes also list rarer ones, like acute sensory neuronopathy and acute pandysautonomia, sometimes linked to specific antibodies.
And the infection link keeps coming up. We mentioned Campylobacter, but the notes list others too.
Oh yeah, viral triggers are common too. Things like EBV, Epstein-Barr virus, hepatitis E, influenza, CMV, mycoplasma, even HIV and Zika virus have been implicated.
Quite a range. So anything that can potentially provoke that immune response and trigger mimicry.
Pretty much.
Now, what about Miller-Fisher syndrome? The notes seem to treat it as distinct.
It is distinct, yeah. Miller-Fisher is fascinating because it presents quite differently.
How so?
Instead of the typical ascending limb weakness, the key features are problems with cranial nerves, specifically eye movements, that's ophthalmoplegia, plus arflexia, like GBS, and ataxia, which is poor coordination or balance.
So eye movement issues, poor coordination, loss of reflexes, but not usually the big limb weakness of classic GBS.
Exactly, that triad, ophthalmoplegia, ataxia, arflexia. And here's a super high yield point from the notes for revision.
Okay.
Miller-Fisher has a really strong link, like 90% of cases with specific antibodies called anti-GQ1B antibodies.
Anti-GQ1B, wow, 90%. That must be a key diagnostic clue.
Definitely. If you suspect Miller-Fisher, testing for that antibody is crucial.
Okay, so we've got the definition acute inflammatory polyneuropathy, the autoimmune trigger via molecular mimicry, often after infection, the variants, including Miller-Fisher with its specific antibody. That sets us up nicely for the etiology, the cause. The notes say the exact cause isn't always clear.
Right. The precise sequence of events isn't fully understood in every case. But the core mechanism is definitely believed to be that abnormal immune response targeting the peripheral nerves.
And the infections, especially respiratory or GI ones, are the usual suspects for kicking it off.
That seems to be the most common pathway, yes. They act as the trigger for the immune system to then mistakenly attack the nerves, causing inflammation and damage.
So who's most at risk? What risk factors do the notes point out?
Well, the biggest one, unsurprisingly, is having had a recent infection. Like we said, Campylobacter is a big one, or viral things like EBV, CMV, flu, other respiratory infections.
Makes sense. Anything else?
Having had GBS before, though thankfully recurrence isn't super common. The notes also mention a potential link, albeit very rare, with some vaccinations, specifically citing the influenza vaccine.
Okay. That association is noted. Important to keep perspective on the rarity versus vaccine benefits, though.
Absolutely. Then there's an association with certain cancers, particularly lymphomas like Hodgkin's disease.
Hodgkin's disease.
Oh,
Okay. And there was something interesting about pregnancy.
Yeah, the incidence seems to go down during pregnancy itself, but then it increases in the months after delivery, the postpartum period.
Huh. Interesting pattern.
Other potential triggers listed include surgery, physical trauma, and bone marrow transplantation.
Right. So once that immune response gets going, what's actually happening pathologically in the nerves themselves? The pathophysiology.
This is where the immune attack focuses on the myelin sheath of the peripheral nerves. Myelin is like the insulation around an electrical wire.
Yeah, helps the signal travel fast.
Exactly. So when inflammation damages that myelin demyelination, Diana, the nerve signals get slowed down, blocked, or disrupted.
Which leads to the weakness and other symptoms?
Precisely. And the notes mention that both arms of the immune system are involved, cellular immunity, like T cells, and humoral immunity involving antibodies.
And for Miller-Fisher specifically, how does the pathophysiology differ there?
So still an immune attack, but it targets different structures, hence the different symptoms. Remember ophthalmoplegia, ataxia, reflexia. The notes say eye muscles are often affected first.
Okay, eyes first.
And here's another key differentiator for revision mentioned in the notes. Unlike the typical ascending paralysis of GBS, the pattern in Miller-Fisher is often described as descending. It might start with the eyes and move downwards.
Descending for Miller-Fisher, ascending for classic GBS. That's a really important contrast.
Absolutely crucial to remember. And again, that strong link, 90%, with the anti-GQ1B antibodies likely targeting specific gangliosides concentrated in cranial nerves.
Okay, anti-GQ1B again. Got it. Now, imagine someone presents with weakness developing quickly. The list of possible causes, the differential diagnosis must be huge.
Oh, absolutely massive. Weakness is such a non-specific symptom initially.
So how do clinicians narrow it down to GBS?
Careful evaluation is key, as the notes stress. You've got to think about other neuropathies, like CIDP, chronic inflammatory demyelinating polyneuropathy. Looks similar pathologically, but it's chronic, develops slower.
Right, not acute like GBS. What else?
Things affecting the neuromuscular junction, the connection between nerve and muscle, like myasthenia gravis or botulism. Even metabolic problems can cause weakness.
The notes give a really useful way to think about this, breaking down causes by location.
Yes, it's a great framework. Is the problem in the brain? Could it be a stroke? Or maybe encephalitis?
Or the spinal cord.
Like spinal cord compression or transverse myelitis, even polio, though rare now.
Then down to the nerve root.
Could be CMV or HIV radiculitis.
Or the peripheral nerve itself.
Loads of possibilities there. Vasculitis, toxins like lead, certain infections like Lyme disease, diphtheria, even nutritional deficiencies like thiamine deficiency or porphyria.
What about the neuromuscular junction again?
Myasthenia, botulism, Lambert-Eaton syndrome.
And finally, the muscle itself.
Things like low potassium hypokalemia or inflammatory muscle diseases like polymyositis.
Wow, that's a lot to consider. The notes really emphasize getting the diagnosis right is crucial for treatment, right?
Absolutely paramount.
Yeah.
Treating GBS is very different from treating, say, botulism or a stroke. Getting it wrong could be dangerous.
Let's talk numbers then. Epidemiology. How common is GBS according to the notes?
It's considered relatively rare. The UK incidence is estimated at about 1 to 2 cases per 100,000 people per year.
Okay, so not common. Any specific groups it affects more?
It can affect any age, really, but the notes say the peak incidence is often between 30 and 50 years old, and it seems to be slightly more common in males.
Right. So let's paint the clinical picture. What does GBS actually look like when it's happening? What are the key features?
The absolute hallmark, the thing you have to remember, is that progressive muscle weakness. typically symmetrical.
And usually starting in the legs and moving up, that ascending pattern.
Exactly. That's the classic presentation. But what else? Tingling or numbness, often starting in the fingers and toes.
Paresthesias.
Yep. And that loss of reflexes we mentioned, areflexia. Difficulty walking, standing, climbing stairs is obviously common due to the weakness.
Does it hurt?
It often does, yeah. The notes highlight that pain, especially back or leg pain, can be an early feature in around 65% of people.
Okay, pain is common. What about the face or head?
You can definitely get facial weakness, making it hard to smile or close the eyes. Problems with eye movement, double vision, or difficulty swallowing can occur too.
And the most serious concern?
Respiratory muscle weakness. If the muscles that control breathing become weak or paralyzed, that's a medical emergency.
Right. So, during an exam, what might a doctor find?
They'd confirm that pattern of weakness, usually more pronounced distally at first. Reduced muscle tone hypotonia. The reflexes would be reduced or absent.
And sensation.
This is a key point the notes make. While patients might report tingling or numbness, objective sensory loss on examination is often minimal, especially compared to the motor weakness. Sensation is generally relatively preserved.
That's a really useful distinction for revision subjective sensory symptoms, but often intact objective sensory function.
Exactly. Doctors might also look for signs of autonomic dysfunction, things like fluctuating blood pressure, heart rate changes, sweating abnormalities.
Okay, so given these features, how is the diagnosis actually confirmed? What investigations are key, according to the notes?
Diagnosis is largely clinical, based on the pattern, but tests are crucial for support and ruling out other things. The big ones mentioned are nerve conduction studies.
Right, we touched on those. They measure nerve signal speed.
Yep. And in GBS, especially the common ADP form, the demyelination slows down the nerve conduction velocity. The signals travel slower than they should.
And the notes had a really important caveat about these, a memory tip.
Yes. Nerve conduction studies are considered the most useful test for confirming GBS, but they can be normal, especially early in the illness, maybe the first week or so.
So a normal early study doesn't rule it out if the clinical picture fits.
Absolutely critical point. Don't be falsely reassured by an early normal result.
Okay. What about a lumbar puncture, the spinal tap? What's the classic finding there?
This is another really high-yield finding from the notes.
Yeah.
Elevated protein levels in the cerebrospinal fluid, CSF, but with a normal white blood cell count.
High protein, normal cells.
Exactly. The notes call this albuminocytologic dissociation. It's seen in about 2/3 of cases, maybe taking a week or two to develop. It's a classic GBS feature.
Albuminocytologic dissociation, got it. High protein, normal cells in CSF, essential knowledge. What about breathing tests?
Critical. Serial spirometry is used to measure forced vital capacity, or FVC. This tracks respiratory muscle strength.
And the notes gave a specific threshold for concern.
Yes, and this is the number you really need to remember for management. If the FVC drops below 20 milliliters per kilogram of body weight, that signals impending respiratory failure.
FVC less than 20 millikilogram means likely ICU admission.
That's the trigger point mentioned, yes. A crucial management threshold from these notes.
Wow, okay, 20 millikilograms. Any other tests mentioned?
Liver function tests, LFTs, might be elevated early on, potentially indicating more severe disease. Blood and stool cultures are sometimes done to look for triggers like Campylobacter, but their value for diagnosing GBS itself is limited.
What about imaging?
A spinal MRI might be done, mainly to rule out other causes of weakness if the diagnosis isn't clear, like spinal cord compression that could mimic GBS symptoms.
And ECG.
Yeah, ECG is important to monitor for cardiac arrhythmias, which can happen due to autonomic dysfunction. And sometimes specific antibody tests, like the anti-GQ1B for suspected Miller-Fisher.
Okay, so a combination of clinical picture, nerve studies, CSF, and respiratory monitoring. How is GBS actually managed then? What's the treatment approach from the notes?
The focus is really on supportive care, keeping the patient safe and stable through the illness, and then specific therapies aimed at shortening the duration and severity.
Supportive care sounds crucial. What does that involve?
Hospitalization is usually necessary, close monitoring of vital signs, especially respiratory function, that FVC.
Yeah.
Physical therapy starting early to prevent contractures and maintain function. Pain management is important too. And potentially respiratory support, like ventilation, if needed.
And the specific disease-modifying therapies, the notes mention two main ones.
Yes, plasma exchange, also called plasmapheresis, and intravenous immunoglobulin, IVIG.
How do they work?
Plasma exchange basically filters the patient's blood plasma to remove the harmful antibodies that are attacking the nerves. IVG involves infusing high doses of pooled antibodies from healthy donors, which seems to modulate the immune attack, though the exact mechanism isn't fully clear.
Do they both work equally well?
The notes indicate that both provide significant improvement compared to just supportive care alone. They offer similar degrees of recovery benefit overall.
Any reason to choose one over the other?
IVGs is often logistically easier to administer, and the notes mention it might have a better completion rate, meaning patients are more likely to finish the full course compared to plasma exchange, which can sometimes be tougher to tolerate, but both are effective options.
Okay. Now, what about steroids? GBS is inflammatory. Surely corticosteroids would help.
This is a massive point, and another key takeaway for a revision from these notes. Corticosteroids are not recommended for GBS.
Really? Not
Yeah.
recommended.
Yes. The evidence suggests they are not effective and might even delay recovery. So, unlike many other autoimmune or inflammatory conditions, steroids are generally avoided in GBS, according to these notes.
No steroids for GBS. Got that locked in. That's quite counterintuitive, but vital to know. What other management points?
Because patients are often immobilized due to weakness, they're at high risk of deep vein thrombosis, DVT, blood clots. So DVT prophylaxis is standard, usually compression stockings and low molecular weight heparin injections.
Makes sense. And the notes mention specific reasons for ICU admission.
Yeah, tying back to the potential complications. Rapidly progressing weakness, signs of respiratory distress, like that falling FVC or needing more oxygen, significant autonomic instability, wild swings in blood pressure or heart rate, or severe problems with swallowing or coughing that risk aspiration.
Pain management, too. You mentioned pain can be bad.
Definitely. Neuropathic pain can be a real issue. The notes suggest using things like opiate analgesics, but also medications specifically for nerve pain, like gabapentin or pregabalin.
And rehabilitation is key throughout.
Absolutely essential. Physiotherapy and occupational therapy are vital, starting early in the hospital and continuing long after discharge to help patients regain strength, mobility, function, and improve their overall quality of life.
Recovery takes time, then. What's the typical prognosis? What does the outlook look like based on the notes?
It's definitely variable. Recovery is usually gradual, often taking weeks to months, sometimes even longer.
Do most people recover fully?
Most people do make a good recovery, yes. The notes mentioned about 80% are able to walk independently again by 6 months after onset.
That's encouraging. But not everyone gets back to normal.
Unfortunately, no. Up to 20%, so maybe 1 in 5, are left with some ongoing neurological problems or deficits. And the notes state that about half of those individuals might remain severely disabled long-term.
That's quite significant. What about mortality? Does GBS cause death?
Sadly, yes, there is a mortality rate. The notes give figures ranging from around 3% up to 10% in different places.
And what's the main cause of death?
Primarily respiratory failure if breathing isn't supported adequately. Also, complications like pulmonary embolism, blood clots traveling to the lungs, infections, especially pneumonia, often related to ventilation or aspiration, and sometimes cardiac arrhythmias due to the autonomic dysfunction.
But early treatment helps.
Definitely. The notes stress that early diagnosis, prompt treatment with IVE or plasma exchange, and excellent supportive care, especially respiratory management, significantly improve outcomes and reduce mortality.
Are there factors that suggest someone might have a tougher recovery? Poor prognostic indicators?
Yes, the notes list a few. Older age at onset, very rapid progression of symptoms early on, the severity of weakness at its peak, and needing mechanical ventilation for a long time.
Anything else?
Having had preceding diarrhea, often indicating Campylobacter, is sometimes linked to a more severe axonal form and potentially poorer outcome. The degree of muscle dysfunction at different time points after onset can also help predict long-term walking ability.
Okay. So, given the potential severity and systemic effects, what are the main complications to be aware of? We've touched on some.
Yeah, let's summarize them. Respiratory failure is the big life-threatening one, potentially needing mechanical ventilation. That's number one.
Right.
Then long-term issues like muscle atrophy, wasting and contractures, stiffness, from prolonged weakness and immobility.
Okay.
Autonomic dysfunction is a major one, causing those swings in blood pressure, heart rhythm problems, arrhythmias, issues with bowel function like ileus where the bowel stops moving, and urinary retention.
Pain is a complication too, that neuropathic pain.
Yes, chronic pain can persist for some. Psychological effects like anxiety or depression are common too, given the sudden and severe nature of the illness.
And blood clots.
Thromboembolism, yes. DVTs and pulmonary emboli are a significant risk due to immobility, hence the prophylaxis.
Infections as well.
Infections are a major complication risk, especially pneumonia if on a ventilator, but also urinary tract infections or skin breakdown leading to infection.
So a really broad range of potential problems beyond just the nerve inflammation itself.
It really highlights how GBS can impact multiple body systems stemming from that initial attack on the peripheral nerves.
Absolutely. So looking back at everything we've covered today, starting with that, that post-infection immune confusion, the molecular mimicry idea,
Leading to the autoimmune attack on nerve myelin or axons.
causing that frightening ascending weakness, the orthorexia. Then there's the distinct Miller-Fisher variant with its own pattern and antibody.
The diagnostic challenge, sorting it out from all those other causes of weakness.
Relying on nerve studies, that classic CSF finding of high-protein normal cells.
The critical need for respiratory monitoring, that FVC threshold.
The specific treatments like IVAGE or plasma exchange, and crucially, avoiding steroids.
And then thinking about the recovery process, the prognosis, and all those potential complications.
It really paints a picture of just how complex the interaction between our immune system, common infections, and our nervous system can be. It's quite unpredictable sometimes.
It really is. And it makes you think, doesn't it? This intricate dance. What does it tell us about the potential ripple effects that even seemingly minor infections might have downstream on the delicate machinery of our bodies? It's a profound connection to consider.
That's a great thought to end on. And that wraps up our deep dive into Guillain-Barré Syndrome based on pulling out the high-yield information from those MSRA revision notes.
Yeah, hopefully we've given you a clearer understanding of the definition, the causes, the symptoms, how it's diagnosed and managed, and what the outlook generally is.
Remember those absolute key features for revision. The ascending weakness, the orthorexia, that albuminocytologic dissociation in the CSF, the nerve conduction study findings, even if normal early, that FVC 20 milligram ICU alert.
And definitely remember, no corticosteroids for GBS, plus the link to infections like Campylobacter and the anti-GQ1B antibodies for Miller-Fisher.
If you found this breakdown useful, whether for exam revision or just boosting your medical knowledge,
Then you might want to check out the resources these notes came from.
absolutely. Have a look at passthemsra.com and also freemsra.com for more excellent revision material.
They're great sites.
Well, thanks for joining us on this deep dive today.
Keep learning.